thank you to all of you who've stayed back after lunch. I know it's a thin crowd, but it'll be sort of perfect because what we are going to have is a fireside chat. And how we expect this is to be a little more informal, to be a little more interactive, right? And basically, this is also the final session of the entire Raise Winter Dialogue Sonipat Ashoka University edition, right? And if I have to think about the one key takeaway that I'm taking from here, it is that technology is going to reward speed, but healthcare is going to demand caution, right? And responsible AI is what is going to be the crux of this dilemma, is going to help us solve this dilemma, right? And what it requires is interdisciplinarity. And in the spirit of interdisciplinarity, we have here two very eminent panelists. We have Professor Arora from IIT Delhi. He is a professor in computer science. And Professor Saini from NIMHANS. He is the professor of neuroimaging. And what we will do is we'll have a very fun, casual conversation about how should we go. I mean, we've had these entire sessions about, we've discussed evaluation. We had a great session on how we should evaluate AI systems, AI applications in health. We've discussed development. We've discussed specific use cases, whether it is in telemedicine, whether it's in mental health, right? But now from deployment, how do we go on to making an impact? How do we get that metric of how many lives have you impacted, right? So how do we accelerate the impact of AI in health is what we will start with. And I'll start with you, Professor Saini, about what you think is the one key win we require in order to achieve this. Use this.
So, at the onset, thanks, Surankar, for calling me. And my take on this is that I will make a honest submission that currently we use very little in terms of deployed AI in our clinical setting. I'll be very honest. And what I use, I will tell you that also. And from that, you can understand. So I use, one is on the dictaphone, dictations, where we use one of the tools. We used stroke detection algorithm, which was very well validated outside in outside world, and it was part of many clinical trials. And the third, where we have recently done, is on a trauma scans, where we are trying to, it auto generates the report based on the CT scan. So that is another experience which I have. And apart from that, there was some experience with the XHS, some experience with the in a very limited setting with the brain tumors. So this is my limited experience in actual clinical settings. So once the I would say one of the biggest challenge is actually integrating into the workflow of a hospital. Every hospital has its unique workflow and its unique demands. So we presume that we have deployed, but actually deploying it and aligning it with the hospital's workflow is one of the challenges. If we have managed to do that, then also solutions which are, I can give you one simple behavioral example of that one. If our MR scanner has got a tool to process a perfusion data right on the console where the data is acquired, out of 100 patients' data will be processed. But if there's a workstation which is kept 10 feet away, this drops down to 70%. If that workstation is kept in a different room, it drops down to below 50%. Data will be acquired, but it will not be processed. So any tool any algorithm which you are trying to deploy, if it doesn't integrate with your workflow and the existing visualization system, it will not be used. It will not be utilized optimally. So that is the. So I'm trying to say, I'm giving you a simple example. If it is a console next to it, it drops down to 70%, 80%. And if it is a different room, drops down to below 50%. Usage will not be there.
Okay, great. So, I mean, you are kind of saying that accessibility and integration within workflow is a big
Very,
challenge.
very important.
Right. So even if we get perfect, if that is
Yeah.
possible, even if we get perfect algorithms and even if we get perfect AI applications, till the time we cannot integrate them into something like electronic health records, etc.
Yeah, correct.
It's going to
Absolutely.
be difficult. So with that, I come to you and basically ask you, as a person who works in computer science, how difficult do you find it to, I mean, for something like integration, you would require buy-in from the user, from the end user. And when you're developing these systems, probably these buy-ins have to come very, very early. If you have to think about integration, probably even before a system has been built, we have to make sure that the buy-in from the end user is there. Do you find it difficult to get people on board, or do you find it difficult to find a common vocabulary when, say, interacting with physicians, when interacting with healthcare professionals?
See, I won't be able to say about general, but I think at IIT we have been very lucky in that sense that we could get very nice collaborators very quickly into our work. Part of the reason could also be that we always took up the problem which were posed to us by the doctors themselves. So it was not that that we developed something and then we are looking for the doctors to really apply it or integrate it. The approach was slightly different, that the doctors come to us with a certain problem that needs to be solved, and then we try to find technological ways to really implement. So in that sense, the buy-in was not that hard for us to achieve. It was, let's say, from day one, we were not really going out looking for it. And once you have buy-in from, let's say, one reputed group, medical group, then it becomes easier to convince the other groups also. So that way we were lucky. It could also be partly that we have been so far working on 2-3 problems, not a lot of them. Maybe once we scale to many problems, it becomes hard to get the buy-ins on all of that. But so far, all the problems that we have been working on, the buy-in has been there from the day one. Or let's say, until we have the buy-in, we have not even started the problem.
Basically, you say that you've been very lucky in finding the right research questions, but then maybe that's something very specific to IIT Delhi. I don't know what is the case in general, and anybody is sort of, please feel free to ask questions. We'll be happy to take those. But yeah, right. Coming back to that, so asking the right question again becomes an important. Uh, Now, from here, what I would like to ask is, I mean, one of the things that revolutionized a lot of AI applications in health is EHR, right? I mean, if you think about United States with their high-tech act coming in, incentivizing electronic health records, we came up with great data repositories which are almost open access. And for a country like India, that has been missing. A lot of it is also attributed to, I mean, of course, there's fragmentation in systems. A lot of it is also attributed to policy. So, do you think this is also a major hurdle that we see in terms of accelerating impact, because that requires scale? And for scale, we require very organized and structured data. Do you think that is a, I mean, we know it's a problem, but how can this be addressed? Yeah.
So I would put it this way, that there's no incentive for doing it. I mean to say, a patient comes in a OPD, you are recording few things. They are very easy to like scribble on a paper rather than entering them in a computer system. And with the kind of load which is there, for example, Safdarjung sees every day 12,000 patients, OPD, 10 to 12,000. With that kind of workload, it is very difficult to have every every record to be electronic health record. Very, very difficult. It's nearly impossible kind of thing. Because in the Western world, there are physician assistants, there are a huge gamut of people around, the core people around, which are helping them. And then we also need to understand that it is not only doctors who are going to make a difference. For example, in an intensive care unit, every recording which is being done is actually done by nursing staff. So nursing staff also needs to be taken into confidence, because those electronic health records, that electronic health data needs to be coming from them. But I've seen that such record is there in certain hospitals in India, but it's very, very small number of hospitals which have that kind of electronic health records. For example, Chitra Tirunal, where I worked, they never in the history after 77, they never had a discharge summary which was not in a digital format. Everything was in a digital format for them right from the inception. But that was a selective referral hospital. They were not seeing every patient being referred there. So it's a big challenge. It's not an easy problem to solve.
So maybe I can just add a slightly different perspective to this also. So to me, EHR is one very important aspect of the healthcare, but it's one aspect. Something that I've seen increasingly, in all domains, not necessarily the healthcare also, is that we are very much inspired by what has been or the way it has been happening in the West. And we somehow treat it as a gospel that this is the way it should be done also. And I think now we have at least few instances like the UPI, etc., where we were able to show that it's not necessarily the only way to achieve that. So I think some of these things may translate to AI in healthcare also, that the West have done in a certain way, and that may not be the ideal or best way for us to do. And we have many more places to create an impact. So I'll just give one example to just illustrate this point, why that is not the case. So let's just consider the scenario, the statistics that, so I work in vision, so I have those statistics. So there are about 20,000 radiologists in India, over a population of 1.4 billion, etc. So somebody will say that, okay, we have about 1 to 10,000. Per 10,000 patient, we have one radiologist, which is a very small, very low number compared to what the WHO will recommend. What statistics are usually not touted in this case is that we have about 1,200 to 1 MBBS doctors. Okay, so WHO recommendation rate is 1,000 to 1. So we are roughly there. If you start counting in the Ayush and other doctors also as the doctors, then we have about 800 to 1. So we are actually doing better than the WHO. So now take these statistics and try to see through what will be our solution strategy. Our solution strategy is not autonomous systems. Okay, so we don't have shortage of manpower, as I told you. So we have 800 to 1 or 1,200 to 1, depending on how you look at it. We have shortage of skilled manpower, which in this case is radiologist. So if we can develop the technology solution which can aid an MBBS doctor to do a job which is equivalent to an MD, you have solved your problem. So you are not looking for an autonomous systems, which would have been the case if I were in UAE. There are just no doctors, radiologists or MBBS. But that's not the case in India. So we have lots of doctors, we have less radiologists. So can we really develop the solution which can aid these MBBS doctors to do that job? And I can do this example in it. It's just like a pyramid system. So you manage to go one level down the pyramid and you suddenly have plenty of resources.
Right. So basically what you're saying is, to accelerate impact, you need to assist and aid, and we need to think differently. We need to think out of the box.
See, look at my own context, look at my own situation, and then design what is best for me.
What is best. Okay. And that's also very important, because 20% of the world.
But then I will give a very interesting statistics. The two branches which AI claims they can actually kill them is dermatology and radiology. Okay. If you go by the statistics of last 5 years, these are the two branches which are being picked by the maximum number of people. And you know which are the branches which are not getting picked? It will actually scare everyone. The most challenging branches are not getting picked up. Cardiothoracic surgery is one of the branch which nobody is picking up. We are soon going to have a situation which is there in many of the Western world, where there are no surgeons to operate. But they can offer money and they can get it from abroad, but it's not a situation for us. General surgery is not getting picked up right now. You see, last year there was a load of hangama that saying that, oh, first 100 nobody picked up general surgery. I'm to say this is actually so which requires skill, which require you need to go inside and operate. No amount of automation is going to help you out. It's ultimately person's skill which is going to matter. So this situation has arisen because of the wrong policies which we have. It's at a larger scale. The problem lies there. But what sir is saying is, I understand it that it can help you a bit, but probably it's not the right way of looking at the problem. But yeah, it can help you in the sense that where nothing exists, for example, in a rural setup where excesses are happening, nothing is there. Anyhow, those cases are not getting reported anyhow. Those situations, okay, something is better than nothing, but not in, let us say, if you try to do this same model in leading public sector hospitals of Delhi, I think the patients, one AI report which came out of All India Institute created a ruckus. So that's just
Okay, so basically what you're saying is, even though we think we are sort of making a dent, but there's this entire plethora of problem statements that are lying, or specialities, like you said, that are lying completely untouched, that may be very difficult. And it also comes back to capacity building. And I'll come back to your question about your point about doctors, the ratio of doctors. And then if you start putting in healthcare professionals as a bigger bracket, the capacity building. So what you're essentially saying is that AI can aid, say, MBBS do an MD's job, or MD do a DM's job. Do you think that kind of, I mean, when you talked about no cardiothoracic surgeons being there, do you think that kind of parallel capacity building routes could be built with the help of AI? I'll give it to both of you there.
no, that is not that. Those are very. I'm trying to say every job is a skill job, no doubt about it. But those are core skill jobs. If somebody has not operated for 10 years in a cardiothoracic setup, he cannot independently operate it, a patient. General surgery also requires certain general surgeon surgical skills. For example, liver transplant. How many liver transplant surgeons India has? Very few. You can count them on fingers. No government hospital can afford a liver transplant surgeon now because their numbers are scarce.
Yeah.
So, but I am trying to say is that, but I will put it in a different way. There are lot of facilities in India where scanners are there, but there's nobody to report them. Okay, so those places this solution works. Something is better than nothing. I'm trying to say that it may not be a perfect solution, but it should come with a caveat that yeah, this is an automated generated data. So we have to be very careful with that one. So when the patient goes with that report, the physician who is reading it, he should also read it with a pinch of salt that yeah, this is not generated, it needs a validation. That's what I'm trying to say.
When you talk about caveats here, I would actually ask you, Professor Arora, what do you think about certain techniques, for example, wearables, for what we call data exhaust, right? And do you think that these kind of techniques can be tapped? And because they're not traditionally considered research, especially from a, say, a public health perspective, right? But then they are very important for scaling up and for covering the gaps that you talk about as well. Do you think these can be tapped for making an impact, knowing very well that it's associated with a lot of uncertainty, may not be perfect, may not be the trained surgeon that we're looking for, but could do, say, take up 90% of the workload?
No, surely. So that can be done, but I'll come to your answer slightly later. I'll just add to what Doctor was saying. See, I don't think in my mind that the AI is solution to everything. Okay, so I don't think that anybody is trying to claim that. So there is a role for the surgeon. There is a role for many other jobs, not only the surgeons in the healthcare. So there is some tiny aspect of the overall healthcare problems which one can either automate or assist through the AI-based solution. So the role of the surgeons will remain there. In the near future, we are not really talking about that, although we are talking about robotic surgeon, but they will still come in the assistive mode rather than in the autonomous mode. So I don't think that's really the point to debate here. So the question really is that with the AI based solution, can we really improve upon the current situation? So, there is a certain level of healthcare services that one is providing. Can we really provide it at a better level? So that's the only. And given our context, what is the right way of doing it? What is the right problem to attack? What is the right way to formulate these problems, etc. So now coming back to your question on the variable. So certainly, I think the variable will be one big area in the healthcare system that is going to come over, that is coming up in the way. And I think that's also rightly so, because the way I see the technology is that there are certain strengths of a technology. I mean, not generally the AI, but any technology system. And then there are always some kind of a weakness of any technology. So in this case, the AI is able to handle a large amount of data very well. That's what we know. There can be certain errors, let's say, but large amount of data processing is possible, which traditionally in the traditional human-based system has not been possible. So whatever, let's say, the pieces of information that we have not been able to use just because the scale of the data is very large is supposed to come back. And that includes the variable. So suddenly, I mean, it was not that that whatever pulse rate my watch gives me for the 24 hours, it's not a useful information. It's a very useful information. But the moment you show it to a doctor for every 1 hour for last 1 week, I mean, I'm just inundated with this information. I can't really make head and tails of it. But with the modern technology, it's really possible to handle this large amount of data. So many of these variables, which are, let's say, which sends a lot of information and often maybe the redundant information, all these data sources is going to come back, and I think as a technologist, we'll try to make use of it. How we can improve the healthcare system through those.
At the point you wanted to say.
Yeah, I always used to wonder that something like very simple thing, stethoscope is the sound which comes from the stethoscope, actually it can be digitized. You'll be surprised to see that only couple of years back that stethoscope came which can be actually plugged into your mobile phone, and it gives you diagnosis.
Yeah.
And you can have a humongous amount of data on the stethoscope and it probably hasn't picked up well because one of these cost is very high. It's around 30,000 to 35,000 which it costs. Second reason is that somehow our healthcare system is more towards like fancy investigations. If you send a lot of investigations, so sometimes actually that in very minimalistic information can be very useful in a very resource poor settings. Like that stethoscope, it's kind of variable. What you are talking about variable, I'm talking about the information which is coming from which is just a recording. You just plug in it to the mobile phone, you get the information. And actually now if you go to a cardiologist, you will observe before he sees you, actually he wants an echo to be done, an ECG to be done, and an X-ray test to be done. 3 things are done, and he will not even use a stethoscope. A stethoscope and actually can replace the echo's role there. So there can be there are very interesting applications which we can actually work on. Already I think this, what is the name of the vendor which we stethoscope, Litman. So Litman has come up with that stethoscope where it's an AI it gives you diagnosis actually based on that phonogardiogram which comes into that. It's an app. Litman's app is there. You connect to it. The sound which comes, it gives you a diagnosis. So I'm trying to say there are very good solutions which can actually, because cardiology setups have got a huge workload. So in such solutions work.
Yeah. So basically what you're trying to say is, let me just sort of confirm if that's what you're trying to say, that the people who need to validate or who need to endorse it do not have the right incentives for that to some extent. Okay. All right. I'll come back to you here. And it sort of revolves back to the first question about what you think is a strategic. Do you think there is space for, say, first fails when we come to AI in health? Do you think we can have first fail, something like, can you have hit and trial methods? Do you think we can have a scope for building systems which can be deployed, piloted, and allowed to fail from a very development perspective? I hope I could get that question.
I did not.
Yeah.
What is the
So for example, if we have something like a system, a AI system, which we've deployed in a healthcare setting, and it's like in a completely trial mode. You're allowing it to test itself. You're allowing it to make itself better, improve itself. Do you think there's scope for such systems in
I think it's interesting. I mean, some related question. I'll just try to interpret it in the way I understood. I was talking on the lunch with Suben also. Uh, can the AI systems continually improve? So in the AI terminology, we call it continual learning systems. So these continual learning systems are very useful in many other applications because, say for example, let's say I do an image search and I'm a Google and I deployed the system, and this is circa 2000. Now at that point there was no mobile phone. Okay, so now 2020 everybody is actually searching for a mobile phone where the system is not even trained to do that. So you want to keep doing whatever you were doing before, and now you want to do one more thing, which is detecting mobile phones. So these are what we call the continual learning system, which can retain their previous knowledge and develop on top of it. There's a lot of scope for that in the healthcare context also, because of the obvious demographic reason. So all the population are different, the operators are different, the sensors are different. So if we want to develop one AI solution, so these solutions are inherently dependent upon one distribution that we have trained on. And the moment I deploy it, the distribution can be something else, which means that the performance is going to deteriorate. Now, one way of improving this performance back is that you take this data from the local center and try to improve upon the system. So you don't want to forget the previous knowledge, and you want to, let's say, acquire this new knowledge which is there on this local center. So this will be called the continual learning system. So there is definitely a scope for applying the continual learning in some of our own research also. We have seen that it is tremendously useful. I think something which has not been settled in this case, but I think that's not settled in a broader scope also, is what is the legal status of these systems. So currently, all this medical AI, let's say, we consider this software as a device. So that's the way we are trying to deploy this system. Because that's how, let's say, the ICMR and all the CDSCO, etc., really understand it. The problem in this kind of a setup is that I develop a particular algorithm. I did a clinical trial. So certain accuracy came, the CDSCO gave me an approval, and I deployed it. The moment I train or I learn the system on the local center data, I have a model B. And that model B is not CDSCO approved. So now we are in this legal black hole of how to really even see this system. So what I will say is that I can understand from the technological perspective, it's a very useful thing to do. But from the legal deployment perspective, it's still a gray area to navigate. So we have to see both the sides of it.
I can add something on it. There are two things which we need to be very clear. No patient actually has an absolute there's no absolute decision making process that which says, okay, is A, now go to B will go to D. It doesn't happen that way. Actually, there's an errors which are happening at every step in that management. They are happening actually. So this is an honest admission. Similarly, we accept that, okay, these tools are also making some errors. The redundancy is there. It may have. So what I'm trying to say is that they need to be monitored, but but to believing that when humans are taking decision, then they are taking absolutely perfectly, it's not the right thing. I'll give a simple example which I gave to give example on the lunchtime also. For example, if I have to read 30 CT angiograms a day, what will happen the morning time when I will be reading? I will be missing less. But by the time evening will have set in, and I would be, there's a mental exhaustion which will be setting in. But with an AI algorithm, if it is designed to identify 3 millimeter or bigger aneurysm, it will invariably, there's no way of it getting exhausted. That human behavioral element doesn't come into the picture. For example, today I had my boss called me and he gave me a blasting, and after that I am reading one CT and there's a likelihood I'm missing it. There are innumerable studies which have actually looked at the error rates. Error rates in the surgical procedures performed in the night are much higher as compared to the daytime. in the morning hours. I mean to say, these errors are there. We can't be saying that whatever is happening in the hospital is a perfect thing. So that errors we can accept here also. I mean, but it requires some sort of monitoring to be there. That's the only point which I'm making. That's where the point. If we start giving them that whatever decision is being taken without an AI is a perfect decision, and whatever mistakes are happening with that are the mistakes only happening with AI. No, that's not the true way of looking at it. And regarding the legal, I would say India is a very, 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 very liberal country in terms of legal this thing. If we are able to provide a service to the patient, he's not bothered about the actually about the quality. If we are actually having an empathy for him, errors is not the problem. There are patients who die waiting for a transfusion, or for example, fluid to be infused, because there's so much of workload that minimal intervention would have done the job, because we do not have a great paramedical system. Like somebody meets with an accident in Sonipat on a road, if the fluid is given on the roadside and fluid is given to the hospital, it makes a difference. He might have suffered an hypotension and a renal dysfunction and consequent morbidity or mortality. I meant to say that don't consider the current health system as a perfect. There is hardly any legal issues in the Indian healthcare system currently with such. Otherwise, how would have been surviving such a poor health records, where one file today, go search for it tomorrow you will not find that file, which ultimately it's all physical. You can lose it. Correct or not? Once somebody wrote, and I give a very interesting example. There was a study published in Lancet. When the Lancet wanted to verify the data, it happened in Muzaffarnagar, a clinical trial.
Yes.
And they said, what was the answer? Answer was the rats ate away all the data of that study.
So I think that's an interesting point you bring forward, and I would also again open it up if anybody has any thoughts or questions on this. I think there is this person here who has a question. You can just get up and speak.
Good afternoon, everyone. And I just joined today because I was busy in some other important works. I have one question from Mr. Jitendar Saini ji. That if you can explain me how AI impact healthcare. It's just basic questions, and that would be great. Both of you can explain on your version.
So I'll give you example. You can understand the impact. When I was a resident working in a medical college in Rohtak, we were doing close to 3,000 X-ray a day. We had a mass miniature radiography of close to 800 chest X-rays, and they were all being reported by 2 or 3 people. What would be the detection rate, missing rates? You can just imagine. This 25 years back, I'm saying. And in the current era, if you deploy the technology there, and you say I can rule out 99.9, so you have to see. I agree, validation is required. Now we are talking that 700, those 3,000 X-ray have to be in digital format also. So if there is a automated report generated, I can just see it and validate it. I think it reduces the burden, huge amount of burden on the. I'm reporting 2025 CT angios right now. If an automated already report is generated, I can validate that. At least I will not. Once report says there's an aneurysm, I can just go through it. Okay, where it is. There will be some sort of, from one reading, now it is 2 readings. More validity will be there. I think it's a great opportunity too. But we should be. It is great opportunity to apply it in the health systems. I'm very convinced about it. There's no doubt about it. But don't think that it will replace humans. There is the problem. When it replaces humans, then legal consequences, ethical issues, everything enters into the picture. So I think look at it from a perspective of a very good assistant rather than being a.
Comes back to the point that you raised about allowing it to take on and assisting a maybe not that skilled person to take over a job. Yeah, but anything else you want to add to that?
No, see, I think the biggest strength of the technology typically is in the scaling up of it. And I think that's what we need in Indian context. And if we apply it in the right way, we should be able to achieve that impact through the scaling.
Basically solve infrastructural challenges that we feel with scale.
So my question is for Professor Arora, and this is something based on what Dr. Saini just said about the human behavior part in the diagnosis of radiological images. He said that during the beginning of the day, a human performs very well because he is fresh and he's not tired. But towards the end of the day, just because he gets tired, and he starts the human's performance starts declining. Now the question is that in the AI field as well, there has been a concern of AI behaving like humans. It might be a very far-fetched concern, but there has been some instances as well where AI machines has been behaving weird. And I don't know if those concerns, if those claims are verified or not. But my question is, do you think in future this exhaustion part can also be true for the AI algorithms, AI systems, and they might also start performing based on the huge amount of data or based on the noise? Might not be the cause might not be the same. Cause might not be the mental as it's the case with human, but maybe because of some other reasons, they also might get exhausted and start behaving weird and performing badly. It's a very hypothetical question, but Dr. Saini, you can also feel free to add in if you want.
So we want to say, is there a data limit beyond compute that we are thinking when we're talking about AI? Yeah. No, beyond compute. I mean, beyond computational limitations, is there data exhaustion that can happen with AI?
What may happen is that so for example, you start over a period of time, some of the noisy data starts coming in, which might start giving a results which we are not probably that's, I don't know, sir will be better person.
Yeah, see, I'm not sure. So the machines are not supposed to get tired. So that part I don't think that should be a problem. But in the machine context, I mean, if I just look at from the data perspective, what is a relevant problem is what we call the data shift, the data drift, or the covariate shift, in the sense that the data is slowly changing with time. So the distribution is not static. And whereas the machine learning algorithm is trained, let's say, time 2024 January, and the data is continuously shifting. So July 24, I'm slightly bad. December 25, I'm slightly more bad. So if you say that over a period of time, the performance is deteriorating, yes, you can observe that kind of stuff. But that's not because the machine is getting tired. That's because the data distribution is continuously shifting. So the more it shifts, the more performance deterioration happens. And the solution to that kind of strategy is something that I was giving an answer to a different question before, the continual learning systems. So the system which can keep adapting to the newer distribution that they are observing.
One problem can happen is that, for example, when we acquire the data, for example, MR machines, as the upgradation of system happens, the image quality changes. Also with the aging of the system, and sometimes technicians can also, like, for example, technician normally a 3D T1 amperage should take around 5 minutes time. He's in a hurry. He wants to go for a coffee. So what he does, he applies a compressed sense on it. So it will do the scan in 2.5 minutes, but will have a noise penalty over it. So if the same, if that scan goes into the interpretation, then if it has not been trained on the CS scans, so those things we require a lot of control. What is coming into the reading room, into the data quality. So there are now algorithms which actually will not allow, which can filter out the data which has QC issues. For example, you can set up a limit for a noise on the data. So probably those can be one of the factors. And as the machine ages, the quality of images starts going down. There's always in CT scans and MR machines, it's a very common problem.
This also reminds me of this news article I had read. I don't know, it's a little unverified, but when ChatGPT had just sort of been released, this was 3.5 if I'm not wrong, and it started giving really short answers near Christmas towards the end of the year, and people started hypothesizing that this is because it's reading the human behavior of going on Christmas leave and New Year leave, and it's vacation time for ChatGPT. But it's interesting that you bring about behavioral aspects and how we can model that into AI learning, and how we can model that. So, for example, fatigue, coming back to that point as well, if that can be used as a, so these are these hidden variables which we do not account for when we are doing, say, something like a randomized control trial for drugs. Now, whether we should, one question is, of course, whether RCTs are the right way of evaluating AI applications. That's an entirely new debate.
But they have been done in few RCTs are
Of course,
there on it.
but yeah, of course. And now whether we can model that and whether it should be modeled in every AI application when it's being evaluated, and basically use it to reduce these unseen errors rather than the more obvious applications.
Difficult question to answer, because as it is what you have tested in an RCT may not be what, for example, the error comes after 1 year. That error might not be at that time the algorithm which was in RCT may not, now it is a modified one.
Yes.
So that's the problem there. So what you tested is not the one which is now throwing the error. So because after that so much of data has been fed into it, and probably the ground truth has changed for it. So that's the
But do
problem.
you think that problem can be solved with this entire concept of adaptive RCTs coming in? Adaptive RCTs and adaptive ones. Yeah. Yes. Okay. Cool. You have a question.
So, thank you for the talk. My question is to Dr. Saini. So, is this a distributional problem that new technologies are not adapted early on in the healthcare? Basically, doctors are not ready to accept new technologies, so new startups cannot really make a thing. For example, agentic AI is very much in, and suppose there are a lot of issues you are talking about automation. These can be handled by multi-agent systems. Do you think there is scope for that?
Yeah, I agree what you're saying. There's a big resistance to change in the healthcare system. Healthcare system actually is very slow to adapt. It doesn't accept change very easily. I'm trying to say is that, for example, if you there are certain reasons for it. I'll tell you what one of the reasons I say. There are some behavioral problems with it. For example, if things starts becoming digital, it also starts bringing in accountability. For example, there is a person who just reports 10 scans in a day, and there is another person who reports 50 scans. Now, to verify that physically is very difficult. For example, you don't have any digital system. Person does only 10 scans reporting, another does 50 scans reporting. Now, the person who does only 10 scans reporting, tomorrow you bring a system which says everything will be now, you have to validate it, and that is going to be recorded now. So now that person will not want it. He will say, why should, if it comes, they will come to know that I'm just doing 1/5 the work which other person is doing. So I'm just giving an example. Or certain, I give an example from practically. One of my resident was there. He used to do very high number of reporting. So when we started seeing, there was another bright candidate. He's reporting very less. But you know what was happening? That person used to identify only the post-op scans, gamma knife patients, which are like single sequence done. So you can just, in 10 seconds, you can actually sign it off. So his numbers were building up very high. There was another person who was doing less because he was reporting spine scan, and spine scans are very tedious to report. You understand? So this kind of digitization, actually now I can identify how many gamma knife scans he has reported because the data is there with me. Whereas that data is not available when it is not in a digital format. So digitization and AI brings transparency into the system which nobody wants. Correct or not?
Nobody wants accountability. Are there any other questions that anybody has?
Hi, thank you for the talk. Just wondering on the concept of accelerating impact in health AI. I was wondering if the definition of impact can also be extended to tools that don't necessarily have a direct clinical outcome per se. So things that maybe impact workflow optimization. Like you talked about patient records, maybe a tool that helps with digitization, hospital administration, those things that don't need to be as over-regulated or maybe don't require such high standards for benchmarking, evaluation. What about those tools?
Yeah, actually, that point which you made is very relevant. So, for example, workflow related, they are low hanging fruits, can be actually applied, and they do not have direct clinical implications. Most often, say, let us say, uh, prioritizing X kind of patient compared to the Y kind of patient. So, I'm trying to say, not because of any other reason, X may be more emergent situation, Y may not be that emergent situation. So, I'm trying to say this can be done. Actually, these are more low hanging fruits and actually can be applied and can be utilized and of great value. It can be of great value. Just for example, I give you simple example. What happened in our place when we were giving dates to the patients? So uh, if what we found that if I give 100 dates for that day, only 60 will turn up. So what we started doing, we started sending an automated message to them. 2 days before the scan, they'll get an automated message, and 1 day before the scan, they will get an automated message that tomorrow is your scan schedule. Our compliance just went up like anything. More than 90% of patients started coming. So this kind of interventions, where if I have to send that message, nobody will be able to send it every day to every subject, but it can be automated from the back end side. These kind of simple interventions can be of great values. And instructing for example, fasting. Some patients end up coming for a procedure, they are not fasting. Such a simple thing, but and it that person wastes his money, our time gets wasted. So all those can be reduced by a very. This is an excellent point what she has made.
No, absolutely. I think there are many other applications which are not necessarily clinical but can have huge impact. So I'll just give again one example from our own experiment/research. So all of us know that we have this MCP card, Mother and Child Healthcare card. So whenever a child gets vaccinated, so there is a nurse who writes that on this date you are given administrator this medicine, this vaccine, and then after 3 months, 6 months, there is this schedule which the baby follows. Now, so I have been a parent myself, and I know that all of us forget. Okay, so when did my child got the last vaccine, and when do I have to go to next? But so for that reason, nurse will typically write when you have to come next. So on that same card, so I administered this vaccine today, and you have to come after 3 months on this date for the next vaccine. So we look at the card, and then we know on what date we go. Now couple this with the fact that half of the Indian population is illiterate. So whatever I have written on the MCP card is useless. I mean, I can't do that. And they are also parent; they will also forget. But that will come up as non-compliance. So the child had to be administered a vaccine, the parent did not come just because the parent forget, and whatever MCP card you gave is of no use on the date because I just can't read it. So one of my colleagues, so he works on these kind of the field areas, so he came to us, Chetan, can you just read the phone number from that card? So the nurse writes whatever they want to write, and as a next step, just takes a photograph from the app. That's all. And so this photograph gets uploaded on the server, and we read all the dates from it, also the name of the patient and the phone number, because that's also on the same card. And what we do is that from that phone number, we know what is the date they should become. 1 day before, an automated call will go that tomorrow there is the vaccination due. Now, imagine that even if this is a technology, so I made 1 in 10 errors. So I read 10 phone numbers. One of the phone number was actually incorrect. Doesn't matter. 9 phone calls went to the right person. And out of this 9, let's say 1 came. So my compliance ratio improved 10%. Now imagine that in a population of 1.4 billion, what a 10% means. So relatively very simple interventions can have huge impact on the overall healthcare scenario. So I completely agree with you. I mean, so many times the impact is many times in the scale part of it, and not necessarily how complicated the solution is.
I'll just add quickly here. If you look at the studies which are coming from China, the patient population studied or even from US. Patient population studied 40,000 subjects. Nobody can sit on 40,000 discharge summaries and actually can extract that information. If I'm just saying I want to look at the outcome of stroke and gender, let's say only two variables are there. We have a discharge summary, 40,000 discharge summaries in PDF are there. So can there be a programs which can actually extract out the gender and the outcomes, the follow-up outcomes, which are there in the digital form, in the digital record system, for example, is there. This is currently nobody in India is able to do it because there are nobody has this technology understanding in the medical field that now with the technology this is actually doable. So there in the research areas there can be huge applications of this kind of algorithm which can extract the information from the digital. It is I actually came to this problem. One of the CMC vendors, one of her faculty was there. She had 2,500 scans, MR reports. So she wanted to write a paper and she wanted to actually get the information automatedly out. She tried in IIT Chennai, but somehow nobody took interest in it. And then we had one student with us she had worked previously in bioinformatics for a long time. She was saying that with NLP I can actually extract it. She did it she wrote an algorithm and actually she would extract it out in 3-4 days and said, this is Excel sheet, you can take it. So I didn't know that by that time, that such a thing is possible actually. So most of these big research studies cannot be done without this technological input. Like 40,000, 50,000 subjects data has to be, and it's a very simplified data which has to be extracted out.
If there are any other questions?
No, I mean, I just wanted to make the point because we discussed about it and Sahaj and Ananya are noting down the points so that we can send to India AI. So since we discussed about the concept of evolving algorithms, so self-evolving agents are coming up right now, but let's not get into that. US FDA currently allows something called as PCCP, which is the Predetermined Change Control Plan. They are the only ones, regulatory bodies, who have understood the problem which you mentioned, that algorithms will have to be changed as per setup, right? The model B, C, D will be different. So if you have a particular mechanism is in place where you tell these are the metrics we'll be looking at after changing the algorithm, so you are allowed to make those modifications for that place. So do you feel that is an absolute must even for India to have that in our CDSCO when they're giving the approvals for such algorithms? Should we also think about that from a policy perspective so that we can start implementing AI more? Because without that, obviously the failure rates at the individual places will be more, and the hesitation for doctors to adopt with those failure modes will be much more higher, right?
No, definitely we will need such regulation or such things to be part of the regulation in the Indian context also. Although I think that the metric part of it is something that it will evolve because it's an evolving field as well. So what exact metric I will test my algorithm against, I think it's not a settled answer as of now. So we know certain things, but I guess that will also evolve over a period of time. But the PCCP or let's say the spirit of it, that the algorithm will change and we have to give an approval in advance to this change algorithm against a certain metric. That principle, I think, is a very nice and should be incorporated in the Indian context also.
There are no more questions. Then what we'll do is we'll wrap up. And I think the major takeaway from this session was that India has a different scale that we need to account for, that when we are handling AI systems in health, and we may not necessarily want to borrow everything from the West or anything outside India. We must contextualize solutions, we must contextualize evaluation, and then we can make impact. And it may come through very simple solutions like workflow optimization through non-clinical systems, right? Thank you so much, Professor Arora. Thank you so much, Professor Saini. And thank you everyone for being here.
It's a special privilege to get it from